I just start saying 2 words about Ramon. So I was digging a little bit in your CV, what you have done in the past. Ramon got his PhD at La Autónoma here in Barcelona, and after that, he also prolonged for his postdoc. So he's graduated. He's a doctor. He's graduated in medicine, but he has done many different studies during his past. He has a master in pharmacology, and he spent some time abroad. He did successful postdoctoral training in Glasgow at the Bison Oncology Center. And I also saw that you did study in neuroendocrine oncology at Uppsala University, which is also something very special, I would say, that makes your background a little bit different from the classical oncology doctor background. Lucky for us, he was back in Spain here at ICO in 2004, where he started working. First, he worked also at Valdebron and in other institutions here in Barcelona, but then he was back here at Bellvitge in 2004, and he continued his career within this institution. He is now head of the oncology unit, coordinator of the IDIBELL program, and associate professor at UV. He has realized more than 200 publications in many prestigious scientific journals, and I would say his major focus throughout his career has always been colorectal cancer, and particularly mechanisms of cancer resistance to therapy. But today, he's going to present something that is probably a side trip in his scientific career that was due to the present circumstances and the COVID outbreak, and probably he is pioneering among oncologists into this management of COVID patients that have also cancer. And this is a very burning topic right now. So I guess we are all looking forward to be updated from you about new findings and new ideas on how to deal with this. So the title of the presentation is Cancer Patient Management During COVID-19 Pandemic, Evidence-Based Medicine versus Heuristic Medicine. Looking forward for your talk, Ramon, please.
Thank you very much for this nice introduction, and I'll go on to the outline. I will start by a few figures, and then before going on to details of the contingency cancer patient management that we have had to do these days, I wanted to make a halt and speak about methodology, how we doctors and particularly clinical managers rationalize knowledge and take this knowledge onto practice. And we have two ways of doing that, as you will see. So let's start with yesterday figures. These are ever increasing. 5 million and excess of 700,000 cases confirmed worldwide, and more than 350,000 deaths attributed to COVID-19 diagnosed cases, which are probably not all the picture of the disease. As you know, I'm not going to spend time on this. This is the most generalized pandemic that we have had since the last century, 100 years ago. So going on to the most interesting part, in my opinion, of the talk, which is the methodology of how we think, how we rationalize in medicine, and how we have taken the decisions that we have taken in an everyday basis since the mid-March, when the pandemic peak started. There are two ways of thinking essentially in medicine. The evidence-based medicine, which is traditional and based in the empirical falsification approach by Popper in the 19th century, a philosopher and a scientist at that time, that gave way to the already legitimate methodology of Pearsonian frequentism statistics that we are already using every day for approval of medicinal new drugs. And this is based in also randomization. So to make a long story short, the downside of this approach is that you need large statistical power, which either means large number of patients included in randomized clinical trial or long time of follow-up, or both. And of course, in a COVID pandemic, we don't have either of those. So sometimes we need to go to the alternative thinking approach, which is more traditional, classical, I would say philosophical approach coming from the inductism, and this gave way to the Bayesian statistical approach. I took this the liberty of using a Wikipedia definition for heuristics, which is any approach to problem solving or self-discovery that employs practical methods that are not guaranteed to be optimal, perfect, or rational, but is nevertheless sufficient for reaching an immediate short-term goal. I'll go back to this along the presentation. So this works more with shortcuts in the mindset, intuition, general knowledge, intelligence. But intelligence is a very big word. So the downside of this is that it's incredible ground for bias. You will see a few examples. Essentially, the basic question of practice of medicine and decision making can be: when do we need randomized clinical trials? And when we need them, we use evidence-based medicine. And when we can manage without them, or when we need them but don't have them yet, then we need to go to heuristic medicine. So just a snapshot, a very synthetic snapshot from a text from Vinay Prasad, which is a fanatic of evidence-based medicine and randomization. This is a commentary in Medscape, available for everyone. So randomized trials are run for interventions that at best offer modest to medium benefit. If an intervention is overwhelmingly beneficial, then we don't need a randomized clinical trial. For example, you don't need a randomized clinical trial to operate an appendicitis, or to operate a lung cancer, or to operate a colorectal cancer. But medicine, and particularly pharmacology, mostly lives in the randomized clinical trial zone. There are few cases that the effects are so immediate and positive that we don't need to randomize to find the truth. But still, a few hundred practices have overwhelming benefit lacking randomized clinical trials. And these lay mainly in the symptomatic and supportive care area of medicine, which is very relevant in the COVID field. So what we do when we need randomized trials but don't have them yet, like in the COVID-19 pandemics, we go back to heuristics. Examples: trial and error, rule of thumb, or an educated guess. An educated guess is the one that we have been practicing these days. This involves observation, experience, induction, intuition, deduction, logics, as I said before, a compendia of human intelligence. But human intelligence is scarce and is not given in the medical school, even with the high marks of medical school. And there is a lot of danger for bias. And this has happened, as again Vinay Prasad has criticized in another commentary, recent commentary, May 20th, in again Medscape, which is a free platform. We have probably faulted the first and primary rule of medicine, which is primum non nocere, first do no harm. And this is because panic has also affected the medical community. And it is common to see physicians using not one, but many unproven drugs simultaneously in such a way that when the patient recovers, we'll never know which one was effective or which combination was effective. And also if the patient dies, we also do not gather information that the medicines are not effective. So with this methodological introduction, I'm going to start with some COVID pandemic facts before going on to the actual contingency cancer patient management that you will see is a mixture of evidence-based medicine and heuristic approach, which is no different than what we do every day in our clinics. So a few facts I want to highlight. The saturations of health services have occurred, and they have occurred in Spain, and they have occurred in crowded regions with international hubs where we have had higher incidence and mortality of COVID-19. There is little evidence that a solution, be it treatment or prevention, is close to being achieved. The most optimistic estimates are 24 months from now for vaccine availability. So all people that are saying otherwise are over-optimistic. It's not my opinion, it's the opinion of Carlos Del Rio, a very expert epidemiologist recently published in JAMA, and I agree. And about treatments, there is only one antiviral that has offered modest benefit, which is remdesivir, and it is not yet available. And probably it will have to be used in combination in the future to derive the greatest benefit, as it is done in the AIDS population. But there have been progresses, and in my opinion, specialized symptomatic and supportive care works, and it reduces mortality. And the mortality of the recent cases in Spain is lower than at the beginning of March, because we are experiencing more on early symptomatic and supportive care. Another very obvious fact is that prevention measures have worked. Robust containment strategies, adequate testing and contact tracing, and special attention to vulnerable populations, physical distancing, and wearing PP equipment, personal protection equipment, frequent hand washing, and staying at home when symptoms occur. Another fact is that we have had, during these 6 weeks of the pandemic, since the mid of March, an excess of death in Spain of 43,000. Of these 43,000 deaths, only 30,000 are attributed to COVID-19. This can be explained by 2 facts. One is that there are more deaths by COVID underdiagnosed, and second, distraction effects. People die of other causes because they do not dare to go to the hospital. Also, effects on cancer outcomes will probably be affected, and these effects, these deleterious effects, will probably be observed in the months to come, because they have also suffered delays in diagnosis and surgery, and also because cancer patients are a COVID-19 vulnerable group. Taking into account all the tradition of thinking of the medicine, the history, and the actual facts on the pandemics, which are the cancer patient management recommendations, starting with the general recommendations. Split teams and shifts according to COVID's incubation time, 14 days. We started like that, and it wasn't possible to follow for logistics. We are not enough people to do that, but at least distancing teams, the physical distance of the medical teams have been very useful, and the contamination rates that we had in the first weeks have improved a lot, and we are not getting any more contagious in the last weeks. Avoid fake news, develop information material for cancer patients. They need to, follow all the general recommendations, even more. I will not read them, you know them all. Masks are, in my opinion, very important when people are in public places. And social distance is the key. While we do not have a vaccine, we need to keep all the social distancing measures, particularly vulnerable populations like cancer patients. We also need to develop psychosocial support for healthcare professionals and patients, and we have done that, and they have been very effective. What about avoiding nosocomial spread and protect healthcare workers? Again, PPEs and triage procedures to screen potential cancer patients that have incipient COVID symptoms. Testing also, in my opinion, should have to be done to every cancer patient entering the hospital. We don't, because we don't have enough resources, but we are now testing all the patients that are going to undergo intervention diagnostics, surgery, but not radiotherapy or chemotherapy, unfortunately. I wish we could. Also, presential visits for cancer patients should be reduced to the minimum. Telemedicine has revolutionized our daily lives. We now do more than, well, we started doing in the peak more than half of the visits by phone. Almost 80% of the clinical visits switched to be done by telephone, and now we are a little bit less than half. We also improved the oral drug supply by courier to patients' home, and we did that with drugs for not just a cycle, but for 2-3 months of therapy. Also, some of the actions that we usually do in the clinics can be done closer to patient homes, like blood monitoring or even local labs. Multidisciplinary team, what we call the committees, the multidisciplinary committees, the functional units, and individual case discussions are done by phone or video meetings rather than presential meetings to avoid healthcare workers contagion each others. Going on to specific cancer treatments. Chemotherapy-induced neutropenia is a risk factor for COVID comorbidity. Immune checkpoint inhibitors, you know that some of their side effects are pneumonitis that share the same pathogenesis as the ARDS syndrome in COVID-19. So this could worsen a COVID-19 pneumonitis, and also other advanced immune therapies like CAR-Ts, T-cell engagers that produce cytokine storm are not the best companion of COVID-19 infection. So we have halted these programs during the peak of the pandemic. More importantly, we have had a bottleneck in diagnosis and surgery, and these delays need to be addressed from a clinical point of view. And before going on to specific details of the contingency plans, some of these measures can be recommended depending on the levels of the health alert, and we have split these levels in low, moderate, or pandemic peak. And these resources change in the different levels, and these different restrictions of the resources will also inform our cancer treatment decisions. So our individual cancer treatment decisions will be based, as I said before, in evidence and heuristics, but also in risk-benefit depending on each level of health alert. And we will want to envisage alternative optional regimens and schedules to reduce hospital visits and risks of toxicity and compensate for the lockdown of surgical interventions. So, as I said before, we have had different levels of restriction of surgery on the different weeks, and we have had to adapt our cancer management to these different restrictions levels, and we have had also to prioritize cases that could not wait over others that could wait for cancer surgery. Radiotherapy has been used as an alternative for radical regimens that may substitute elective surgery when there is enough evidence that this will not jeopardize the long-term outcomes of the patients, and also to avoid or to reduce frequentation of patient visits to the hospital when available and evidence suffice. Shorter accelerated or hypofractionated regimes of radiotherapy have been preferred. A few examples: we have prioritized breast cancer surgeries in different priority levels. Those that are higher priority are the more aggressive localized cancers. And for these cancers, as you will see later, sometimes we have changed the strategy if the surgery was completely locked down, and we have treated these highly aggressive tumors with neoadjuvant treatment. Another example of substituting surgery for something else is head and neck cancer. We have some cases where the surgery is locked down, that radiotherapy is a good alternative as a radical treatment. And we have used these radical radiotherapy treatments for treating resectable disease. And we have used also hypofractionate treatments from the more standard long course chemoradiotherapy treatment for unresectable disease. This wants to be just a few examples of how we have tried to adapt to the specific circumstances on an everyday basis. Regarding chemotherapy, we have also always checked for oral alternatives if available. And for the adjuvant setting, we have prioritized patients with high-risk disease who are expected to derive a significant absolute survival benefit. During the peak of the pandemic, we might have been more prone to not give adjuvant chemotherapy in those indications that are more dubious. And we have prioritized neoadjuvant regimens, as I said before, to mitigate lockdown of surgery in the severe pandemic period. For example, I am a colorectal cancer specialist, and was as was mentioned before, and in the stage 2 colon cancers, we have vivid debates for decades whether chemotherapy should be given or not. And for example, these days we have not been so inclined to prescribe adjuvant treatment for low-risk stage 2 patients. And also a highly debated controversial trial, which is the IDEA trial, that compared 3 versus 6 months of chemotherapy treatment, and it was generally a negative trial. But now we have prioritized a regimen, which is an oral regimen, mainly oral regimen, called CHELOX, in which 3 months were equivalent to 6 months in the subgroup analysis of the IDEA trial. So we have been more inclined to accept this result as we used to be before the COVID-19. The same has happened with the Foxtrot neoadjuvant colon cancer trial, which essentially was a negative non-inferiority trial, but for some subgroup demonstrated that neoadjuvant chemotherapy was effective and safe. And we have contemplated the use of neoadjuvant chemotherapy in colon cancer in bulky disease, locally advanced colon cancer patients that were fit for surgery, but during the peak of the pandemics, they didn't have access to surgery. Rectal cancer is usually treated with neoadjuvant treatment, but we have changed the regimen. We usually left the chemotherapy after surgery. So the standard for locally advanced rectal cancer is chemoradiotherapy followed by surgery, followed by chemotherapy. And what we have done based in phase 2 data is to put chemotherapy also before surgery, to postpone surgery in some selected cases, as in what is called total neoadjuvant treatment. Another example of contingency plans. Regarding the metastatic setting, there was some voices that advocated for delaying palliative anti-cancer therapies. I am not in favor of that because there is enough evidence that delaying palliative anti-cancer therapies is no good for overall survival of the patients. In other words, early anti-cancer treatment in metastatic setting improves survival. maybe in more advanced disease, third, fourth, even further lines of chemotherapy, when the patients are already very sick, more consideration can be put into the symptomatic and palliative care treatment only without toxic treatment than what is usually applied in settings before the COVID-19. Other considerations are therapy holidays in some cases where there is evidence that these do not jeopardize long-term survival. And also we have been prolonging neoadjuvant treatments with chemotherapy in liver metastases to delay surgery of liver metastases. Does palliative care and symptom control also improve survival in cancer patients? I mean, cancer survival? Yes, it does. So again, it's good to remember that having a very aggressive symptomatic approach and support care approach for cancer patients improves survival. This is general recommendation that is even more important in the COVID-19 era. So I will end with explaining the impact on cancer clinical trials. Cancer trials are complex, as all clinical trials. There are many different processes: administrative, medical, clinical, pharmacy, nursing, and data management, amongst others. And essentially, the pandemic has affected all of these processes. There have been guidelines produced by all the major agencies ruling the business: the Spanish AGMED, the European EMA, and the American FDA. Interestingly, these guidelines are not very similar amongst them, which is not unpredictable coming from this field, which is highly charged with quality debates and bureaucracy. But they all deal with these different processes, site visits of patients, recruitment, and treatment availability, informed consent, monitorization, initiation visits, and telework. And they even consider transference of patients from one center to another. And finally, they regulate the reporting to ethical boards. In a very brief way, I will summarize what has happened in our hospital. During 3 weeks, we shut down all recruitment and presential monitorizations were suspended. Remote monitorizations were considered, but so far we have not felt it has been necessary to run them. There are legal issues on the internet sharing of the medical records that need a little bit more of fixing before this can be implemented as a solution. but we're almost there. So remote monitorization could be a solution in the future. I hope we will not need it, but let's have them in case. And then we have managed to follow procedures per protocol procedures of all the patients already included in clinical trials. But we have been obliged to do deviations. All the deviations are minor. They don't affect safety, and they need to have been accepted by the sponsors, retrospectively or prospectively. Better if it is prospectively, but sometimes for the safety of the patients, the decisions were made without acceptance, explicit acceptance of the sponsors. We have done start visits, virtually, remote start visits, and some semi-remote, semi-presential for starting new clinical trials. All the data managers have had remote access to all the systems. And finally, some data. Recruitment in March was even superior than last year, than March last year. That means that we were, like a rocket this year, and we were very proud. We were going to break all the historic records of clinical trials recruitment in cancer until the COVID-19 arrived. And in April, we decreased 80%. We shut down for 3 weeks. And May, now we are in 50% of recruitment. This has been a shock. All the new regulations for spaces apply very heavily on the logistics of clinical trial development, and all our internal planifications for nursing staff, for data entry staff, for pharmacy staff needs to be reviewed. It's tremendous, the impact that this has is very important, but we are on a daily basis working to find solutions. Every day we are better in selecting which tasks can be done from home, which tasks need presential, but at the end of the day, we will need more space if we want to continue with the same level of clinical trial activities as we had before. And this is going to be challenging for IDIBELL and ECO, and this will need a lot of talks and understanding and discussions between the direction of IDIBELL and the direction of ECO to offer solutions that allow us to continue with the level of activity in clinical trials. I finish with take-home messages. Contingency preventive measures to mitigate direct and indirect effects of COVID in cancer involve decision and thinking based both in evidence-based medicine and heuristics. Decisions are needed at 3 levels: community, nosocomial, and individual. COVID situation reinforces the relevance of evaluating risk benefits to take the most appropriate decision in each individual case, in each individual level of health alarm. And clinical trials crisis management has been crucial and will remain to be crucial to maintain both safety of patients and business continuity. If we do not put intelligence, cooperation, and more space, the business continuity of clinical trials in cancer is at jeopardy. With this, I am finished and I am ready to take questions.
Thank you, Ramon. Again, it was a great talk and I think very actual, raising a lot of points that are of interest for all the scientific community. I start posing a first question. You know, there is nothing so stable as a change. And I was wondering, during your talk, you gave the impression that some of these aspects might be temporary due to the pandemic, but I think that some of the action we will take right now will change completely the way we will face medicine, not in a temporary way, but will be much more stable. Do you think that I am wrong? So what do you think could be really reshape or should be really reshaped in a longer term perspective, not only now due to the pandemic?
Yes, thank you for this question. Mainly, to give a brief answer, all the actions, all the decisions related to connectivity and telemedicine are here to stay. This will be for us forever more. Other aspects of cancer treatment management can reverse and are hopefully reversing. So we are back to full bloom operating activity at Bellvitge Hospital. But, you know, all these safety measures to avoid nosocomial infections are here to stay. And this is, if I may, a collateral positive effect of the pandemics.
Yeah, because nosocomial infection, particularly pneumonia infection among elderly, for example, in hospital settings is quite dramatic. And I think this approach of telemedicine is definitely very interesting and something that I also see as a future long-term stable approach. I see Christina as a question. Please, Christina, unmute yourself and join into the conversation.
Hello, thank you, Ramon. I wondered if there's already any data, even observational, about patients that have been were treated with immunosuppressive chemotherapy or the opposite immunotherapy, and they contracted COVID. Then, do you know already if there's any data about whether they did worse or they even did better, like initially they were ideas that immune cytokine storm was part of the disease?
No, they did worse. There is only one Chinese paper that I know of so far, but there are other observations being reported as we speak. And in these observations, the mortality in cancer patients was 30%, and this was worse for patients that had lung cancer and that received active treatment. Data is still not there yet to elucidate whether immune checkpoint inhibitors make it worse than chemotherapy for patients who then go to have COVID-19. But it's not a good idea to mix these treatments with COVID-19, that's for sure.
All right, thank you.
Julian, Julian, sorry if I'm not right. Julian, sorry. Okay.
Thank you.
Please.
Hi, Ramon. Thank you for your talk. So it's something I learned from you guys, from the oncologists through the years, is that the best thing to treat cancer is surgery, right? So thinking in an analogy with the COVID-19, the best way to treat this will be to do tests and detect those people that are infected and then isolate the infected. So you said that probably the vaccine could take like 2 years. So that means that probably we should look for another solution. So the question is, do you think that could be feasible to make tests in a cancer hospital, like to everyone, one per month? So in that way, we can locate people that is infected and isolate them. Probably could be the way to keep the activity to close to normal.
Yes, yes. I think and this again is heuristics medicine. This is a very obvious measure that would mitigate the pandemic. Periodic tests in every cancer patient that comes to hospital for treatment. I wouldn't go on a monthly basis. I would do it every time the patient comes to receive treatment, which may be every 2 or 3 weeks. Maybe it would be too harsh to do this to the outpatient clinics, but the outpatient clinics can be separated and is physically separated from the actual hospital, and for the outpatient clinics, we can use all the PPE and use just the triage clinical symptoms for choosing only those patients that have had dubious symptoms or have fever to do the tests. But for sure, all the patients that would enter the actual hospital for some procedure or treatment, in my opinion, it would be a good idea to test them.
So it could be possible. It could be, you think, could be possible in terms of logistic and in terms of the cost?
It is not possible today, Julian, but I think it should be possible.
And going on this point, how sensitive is this test? You were saying before that detecting COVID early is important also in terms of disease management. How early can the PCR test detect COVID patients, so COVID positivity? Do you have any?
I am not an expert, but I have read a lot and I have talked a lot with the experts these days. So I can tell you that it is very, very sensitive. The PCR is very sensitive, even in early days. But of course, it's not 100%. We have had a colleague of my department that had 2 negative PCRs before being diagnosed, and she had to be admitted to hospital, and then fortunately she recovered, but it took her 1.5 months to recover.
And is an early detection truly helping also in terms of disease management? I mean, I guess for a cancer patient, it could be important also to decide follow-up therapies if there is any possibility to be reshaped due to COVID positivity. But in general, for disease management, if you detect very early the disease, is that important, or is more important to take care of the symptoms, so even in the absence of a clear PCR positive test?
I will answer the part on the cancer patient, okay? It is crucial for for different reasons. One, because you do not want to treat a COVID positive patient with an immunosuppressive or an immune therapy treatment. We have already discussed that before with Christina. Two, because you avoid spreading the nosocomial spread of the virus, and also the community spread of the virus around this index case. And then three, cancer patients are vulnerable per se to COVID, so you have a very low threshold to admit the patient to hospital and do all the symptomatic support and fluids and etc. All these measures that are not particularly antiviral treatments, but that are supportive symptomatic treatments that, from an heuristic analysis, I believe reduce mortality of the COVID itself.
I see. Yeah, it's very complex. I also want to raise another last point, and is about how and to which level inform community about this change that therapy is going to take and is taking right now, because this should also be somehow well communicated, and patients should be informed when they are offered telemedicine, the reason for it, and when this is so all the change in the therapy that they might expect because of the pandemic. Do you have any contingency plan also in this direction, so to inform the community and patients on the changes? Because I think that is also something that might require some attention from the medical part. Because if I would be a patient and you say, okay, right now because of the COVID I change your therapy, that can be a little bit destabilizing, I think, or it has to be handled differently. Or if I was used to see you for our weekly meeting and discuss my therapy, now we talk at the phone. So also that is something that I think needs to be well discussed with the community. Do you have anything in place for that?
This is a huge question. Thank you, Maria Carolina. You are really putting very interesting questions on the table. Huge. We have worked day and night for the first weeks of the COVID to change all the protocols, to change all the standard protocols and the standard consent forms of the protocols, and also telemedicine consent processes. It's been a nightmare, yeah. And we've done that. So the patients are fully aware of all the consequences. They are also fully aware when they receive an alternative treatment with regards to the risk-benefit ratio of the different levels of the health alarm. And also the first part of your question, in terms of general information, many scientific societies have published papers on these issues. They are very general papers. I don't have time. If I had time, I would publish a more specific papers. People don't like to go on to specifics. They don't like to publish that with these alternative treatments, there may be some loss, some damage.
Yeah, but I think it's an important aspect, because when you are into that, at that point you want to have all the specific details, no? And at that moment it's important to be communicated. And in general, I have the impression that through the public media, there are a lot of different messages. Sometimes the picture is a bit confused and people feels a lot the uncertainty. And I think it would be very important to communicate that the medical community, the oncologists are really working on very careful protocol that are first prioritizing the well-being of the patients. And sometimes I have the impression that people just react by saying, I'm scared, I will not go to the hospital even if I have an emergency, or I don't trust anymore what they are saying because it's everything changed now. And I think it's an important aspect, and also something that maybe for the future should be considered a stable part of the hospital setting. So explaining carefully to the patients all these and how this might change in the presence of a pandemic. I don't know. Do you think that this is also going to be a longer term point? So communicating.
Absolutely. It is a very important challenge how we communicate that to the community. As I said before, and it's important, I want to leave this message across very clearly. On an individual patient per patient case basis, we've done that, and we have produced all the information and consent process. For example, you have breast cancer, 1.5 centimeter breast cancer, and you need surgery. And the surgery is going to take more than 6 weeks. And then you have to decide, you wait for 6 weeks or 8 weeks, or uncertainty, because you don't know when will you have your breast cancer removed, or you decide to do a neoadjuvant chemotherapy that is effective for the type of tumor that you have and can have secondary effects that you wouldn't have if you would go straight to surgery. This kind of discussions is the ones that we have been having with our patients.
Yeah, no, I see that's difficult and requires special care due to the situation and discussion also. I have probably the last question on my side on telemedicine. This is also an interesting topic, and this is something that you mentioned now in the context of cancer patients. How widespread is, in your opinion, that going to be? I mean, I think it would be an important option also for family doctors and for everyday healthcare support to implement more telemedicine. But again, I see this also as a longer term perspective. What do you think? Is has something that should be considered broadly?
Yes. Again, there is always a lag time before technology is routinely available to really get to every corner of healthcare. And so we talk of telemedicine now, and we are all, very fashionable because we do telemedicine. No, we don't do telemedicine. We do phone calls to our patients, okay? And there are a lot of systems that are high technology telemedicine systems that will, for sure, aid us in the future, and I hope in the near future. But what we are doing now is a prehistoric telemedicine. With this, we have mitigated the pandemic peak, all right, but we need to do the second part of the telemedicine revolution, to get these systems everywhere, so that we can really say that we do telemedicine. And again, I think this pandemic will be very, very helpful in convincing policymakers that this is the way to go.
Good. Yeah, it's a good point. And so thank you again, Ramon, for sharing this very actual perspective on how oncologists may be dealing with their patients during the pandemic, and to discuss with us all these points that I think are very important. And for right now, if there are no other questions, I think we can stop here for today. And thank you for everybody for attending. Again, thank you, Ramon.